Okay, so this is a assessment for lumbar spine. Obviously making sure that we look at the hip complex as well to ensure that we've got no hip coexisting, pelvic coexisting condition with the lumbar spine. So the first thing we want to do is just observationally just have a look at the lumbar spine. So Corinne, if you can just move around and just ever so slightly again just towards the camera, just perfect. So we look at alignments, we look at any discoloration, any scarring on the surface of the tissue, have a little look at symmetry and muscle bulk as we move down from cervical through thoracic into lumbar spine. Just going to roll those shorts down ever so slightly. Muscle bulking through the paraspinals is important. Obviously making sure that we've got no hypertrophy or atrophy in either of those areas. A good indication of any issues with symmetry or any alignments, muscle bulk, any issues there is the amount of skin creases through the keyhole, through the lower thoracic into the upper lumbar, which is fairly symmetrical at this point. So then we just want to have a little look and we'll check glute creases, both sides. We'll have a little look to see, to make sure they're both symmetrical. There's no significant muscle bulk or there's no significant atrophy again. So the first range that we want to test actively is into flexion. So Corinne, if you can just put your hands on the front of your legs for me and then just run your hands down the front of your legs as if you're going to touch your toes. Okay, and just hold that there for me, that's fine. And again, we just look to see any symmetry, any muscle bulk, any significant issues there. Nothing sclerotic that we can pick up, you know, which is apparent. And come back up for me. Okay, perfect. And we can test that 5 repetitions as continuing repetition through into flexion to enable him to obviously check the range, make sure he can touch his toes. So the next range that we want to do is into extension. So I'll place my hand onto lower lumbar, look up to the ceiling for me and then come all the way back. That's fine, and then back down into neutral position. Any pain obviously would indicate possible dysfunction there. Maybe also looking at possible links to any sponding condition, spondylolisthesis, spondylosis, which would be related again to a pars interarticularis fracture, which we could again pick up with monitoring our capsular pattern, extension, flexion, lateral flexion. Hands on the sides of your legs now. So what I want you to do each side one at a time, just try and touch your toes for your right side. Again, making sure we're looking through observationally movement, that's fine. Opposite side. And again, just asking about pain, levels of pain throughout that, and again measuring sort of dysfunction to see if there's any restriction in that active range. Okay, and then hands to your chest. Most of your rotation, again, if you just rotate through, yeah, and then opposite side again for me, coming around to the right. Perfect. Let's do that seated. Making sure they're seated will restrict any rotation into the pelvis. Okay, so while we're in a standing position, we can look to see the ability of L4 through dorsiflexion. So we get the athlete to walk onto the heels in place. So if you just walk in place on your heels for me, keep going, that's fine. Obviously any pain, indication, loss of balance, inability to maintain good posture may be related to a possible L4 issue. And then if we're coming up onto the toes now, please for me, and then again just walk in place on your toes. Okay, and again, on your toes is related to your S1, your sacral 1 nerve root. Okay, perfect. Right, so we want to move on then to our neural tests. So if you go and just seated there for me. So to test the motor nerve initially, the first thing we want to do is hip flexion. So we resist, obviously feet off the couch, don't support yourself, so you're just bringing your knee towards the ceiling for your resistance. Okay, full effort, there we go. Opposite side, obviously bilateral comparison, contralateral, bilateral markers, and then relax. So your L2 for your hip flexion, then you go into L3 for knee extension. So push away from me, and again both sides, full effort just to see again the ability of the motor nerve through L2 and L3. So hip flexion, knee extension to L3, and then we're moving down to L4, which is dorsiflexion. Again, we test it actively, functionally. So what I want you to do is just bring your toes up to the ceiling for me, okay? And again, resist both sides. Again, and just to test that L4, lumbar 4 nerve root. Great toe extension then is through L5, so just extend the big toe for me. Again, you want to make sure, and again, bilateral comparison to see if there is any dysfunction, if there is any pins and needles, numbness of the cremus currently carrying a proximal metatarsal phalangeal issue, injury, sprain, bit of connective tissue damage there for about 5 to 6 weeks now, so we're currently working through that. And then into our S1, cycle 1, which is our plantar flexion. Okay, so what I want you to do, if you dorsiflex for me, and then press away, and then again, opposite side, and then press away for me. And again, just resisting, activating the motor nerve. Okay, and then our sensory tests. So with our sensory testing, we want our L2, which is our anterior thigh, L3, which is the medial knee, and then right the way down into the S1, which is the heel. So our sensory tests, we could use a pen, a marker, just to make sure we've got all the sensory areas through the anterior thigh, the medial knee, down onto the sole of the foot, plantar surface, and then down onto the heel. Any sensory issues, pins and needles, numbness, paresthesia, loss of sensation, paresthesia, inability to tell the difference between hot and cold. So things that we want to look at and monitor there as well. Okay, so now that leads us to our functional tests. Those are the first functional tests we're going to do in this position. Is going to be a seated straight leg raise. So again, making sure the hips are nice and stable, nice comfortable position, big deep breath in for me. And then what I want you to do is just extend that right leg. Dorsiflex, neurotensioner. Any pain there at all? Bring your toes back for me. No pain there? No. And again, contralateral side. That could indicate that there is a nerve root issue, usually lower into lumbar. L4, L5, S1 are our main points of problem with the lumbar spine, main pivot points, main low points. So you can extend that then to a slump test if needs be. So chin to your chest for me, big deep breath in, and then slump yourself forward without supporting yourself all the way down. Perfect. We then want to extend the right knee, bring the toes into dorsiflexion, again stretching the nerve root, and swap over opposite side. Same again. We can also apply a little bit more pressure to the back of the head to stretch those nerve roots as well. Okay, so that would be a positive sign: numbness, pins and needles, paresthesia, pain, lower back. Differentiate between hamstring tightness and obviously any nerve root issues. Flatten your back then for me, please. Next test is a straight leg raise. So the straight leg raise is really, really important because we're testing the range of motion. We're looking between 0 to 35 degrees. We're starting to take the slack up of the sciatic nerve. 30 to 70 then, we've got the nerve on full stretch. So it's important to differentiate between our hamstring tightness and obviously our nerve root issue. Instruction needs to be to maintain good hip position. Just check lower back there, make sure we've got good position onto the plinth, onto the couch. So with your right leg from the hip, keep your knee straight leg raise up to the ceiling for me, please. Okay, so again, the range is relatively good, just under 90 degrees. Tension then with dorsiflexion, and that brings on a little bit of pain. Again, back of the knee and lower down, and pain, refer with pain patterns, track patterns can indicate that there is a sciatic nerve issue, nerve root issue. Opposite leg, comparable, and then dorsiflex. Again, we can also, just relax me, take an off stretch, and if that reproduces the pain, then it can obviously indicate that there is a nerve root issue. Okay, in this position we can run through Faber's, which is flexion, abduction, external rotation, and this can stress out the sacroiliac joint. It doesn't confirm, but it can be a suggestive test. So what we want to do, we want to flex the knee and flex the hip. We want to abduct and then externally rotate. Okay, so the tested leg is placed on the contralateral knee into that position of flexion, abduction, external rotation. Stabilize pelvis, ASIS, and then just apply a little bit of pain. Provoking pain, would be into the SI joint, and that can obviously be tested contralaterally, bilaterally rather. Flex up, across, stabilise again to stop any rotations, and then press down into that position. Again, trying to provoke the symptoms. So that's Faber's or Patrick's test. The next test that we want to do, or we could perform, is Gainsland's. So we're on Gainsland's. Green, if you just lie on your right hand side for me. Okay, this bottom leg needs to be flexed. So bring this up to the chest. Perfect. And then what we want to do is we bring the hip into extension. And we're looking to see any pain there, any provocation of pain, and Gainsland's to then obviously assess lumbar, differentiate between lumbar and sacroiliac, and again we would do it on the bilateral side. Now from that, we want to basically differentiate between what we know as waddle sign, being a psychological or a non-organic pain presentation. So we can go flat in the back again. And this is called Hoover's test. We can link this with our SL, a straight leg raise. So if we think we might have malingering, or there is a secondary possible concern in terms of getting the athlete out playing again. So with your left leg, I want you to bring it up to the ceiling with your knee straight. With your right leg, you're pressing into my hand. Okay, and it should be comparative both sides. And push again. Perfect. And you can see that the effort there is matched both sides, so we can understand that it's not a malingering athlete, it's not an athlete who has got any issues that could be either psychological or trying to prevent them from playing or training. Okay, to differentiate again between hip and coexistent lower back, we can work through an impingement test. So, you know, if you're not too sure whether it's either a hip impingement or there's a snapping hip even, we take the knee and the hip into flexion, okay? We internally rotate the hip, and then we abduct, and we're looking to recreate pain, symptoms, and we apply a little bit of pressure through and down, trying to drive the head of the femur into the acetabular. And again, just communicate throughout. This can be done again bilaterally, but that can be used to differentiate between any lower back pain, any referred pain patterns into the hip complex. Okay. And then the last one that I want to run through is a Trendelenburg. So if you just hop down here for me, please, Kareem. Now, Trendelenburg sign is either going to be a hip, a glute medius weakness, or hip instability. So from this position, if you just turn and face the wall, if you please, Kareem, just all the way around. Okay. And now what I want you to do in that position is just flex the knee to 90 degrees. Okay. Here we're looking for the instability or possible instability of the hip complex, palpating through, obviously to see the line of the PSIS. We would have a significant drop on the supporting leg, and that would be Trendelenburg sign of the glute medius weakness. Opposite side for me, swap over. And again, just take a little step back, just to monitor, just to identify if there is any issues. From there, if that was a positive, and relax me, okay, there's a test called a pull arm test, a lateral pull arm test. And this is performed by stabilising the elbow. I want Kareem to fight against the resistance, basically. Okay, so this is again going to identify which side is dysfunctional, which side is going to be painful. So, with an inferior force, nicely braced, stabilised, come against my, and you pull down, 5, 4, 3, 2, 1. Obviously we clear Kareem of any shoulder issues beforehand, any dislocations, any instabilities. And in the opposite side, so inferior force, and brace again for me, 7, 6, 4, 3, 2, 1. Any pain lower back?
No.
All good. A bit more precaution, Kareem in that position, obviously due to previous elbow surgery. And then the last two signs that I want to run through is Clonus and Babinski's, and these can identify upper nerve root lesions as well. So again, just to differentially diagnose. So if you just go flat your back again for me. Okay, Babinski's sign is running an object It could be a reflex hammer. In this case I'm using a board marker, and what we're running through is running along the sole of the foot, lateral border, across the head of the metatarsals. A positive sign, which would be a Babinski sign, would be fanning of the toes and extension of the great toe, and that's a sign for an upper nerve root lesion. Okay, clonus sign then would be, and you just see it there for me, pretty please. Clonus sign would then just be an involuntary movement of the ankle, and we can see we can press through various points through that. Clonus sign would be a sustained involuntary movement of the ankle. In this case, obviously that's positive. That's negative, sorry, we're correct. Okay.